The nurse who was always there, based on a real, documented case. For years, the staff at a small pediatric hospital believed they were dealing with bad luck. That was the only explanation that made sense. The ward wasn't understaffed, the equipment wasn't outdated, the doctors were experienced, and yet, children kept collapsing. It started quietly. A toddler admitted for a mild infection suddenly went into cardiac arrest. He was revived, stabilized, and everyone agreed it had been a frightening anomaly. A few weeks later, a baby being treated for dehydration stopped breathing without warning. Again, the staff responded quickly. Again, the child survived. Doctors reviewed the cases and couldn't find a clear cause. The children didn't share the same diagnosis, their conditions weren't severe enough to explain what had happened. So the incidents were documented and dismissed. Then another child collapsed. This time the resuscitation took longer. The child survived, but only barely. Parents began to talk in waiting rooms. Nurses whispered at shift changes. Doctors started double-checking charts late at night, searching for something they had missed. There was no obvious link, no contaminated medication, no faulty machines, no infectious outbreak. But there was one thing no one wanted to say out loud: a pattern. The collapses were happening on the same ward, often during the same shift, and almost always with the same nurse nearby. Her name was Beverly Allett. She was in her early 20s, soft-spoken, attentive, known for being calm during emergencies. In fact, that was one of the reasons no one suspected her. When alarms went off, Beverly was already there. When children stopped breathing, she was the first to notice. Doctors praised her instincts. Parents trusted her. She had a way of making people feel reassured, even in crisis. But as the weeks went on, the incidents escalated. One child died, then another. These weren't critically ill patients. Some had been admitted for routine issues. One was almost ready to be discharged. Autopsies were inconclusive. Causes of death were vague: natural causes, complications, sudden unexplained collapse. The hospital was devastated. An internal review was launched, but it focused on procedures, not people. Policies were adjusted. Monitoring increased. Still, the collapses continued. One doctor, growing increasingly uneasy, decided to do something unofficial. He began writing down names, not diagnoses, not symptoms, just names. Names of staff on duty when incidents occurred. Over time, one name appeared again and again: Beverly Allett. At first he tried to rationalize it. She worked many shifts. She was often assigned to high-needs patients. She was proactive. But the odds became impossible to ignore. In 1 month alone, there were more medical emergencies on her shifts than the rest of the ward combined. The doctor shared his concerns with hospital administrators. They hesitated. Accusing a nurse, especially one who appeared dedicated and compassionate, felt unthinkable. There was no direct evidence. No witness, no confession. Then something happened that changed everything. A baby admitted with breathing issues suddenly went into cardiac arrest. Resuscitation efforts failed, but this time blood tests showed something unusual. High insulin levels, far higher than what the child's body could have produced naturally. Insulin, in a patient who wasn't diabetic. Investigators widened their review. They re-examined prior cases. They noticed similar unexplained metabolic imbalances. Sudden drops in blood sugar, electrolyte disturbances, symptoms that didn't align with the children's conditions. And in nearly every case, Beverly had been present. Police were notified. Quietly, they began monitoring her shifts. They reviewed medication logs. They noticed discrepancies. Medications signed out that had no documented medical reason. During one shift, a child suddenly collapsed. Beverly had been alone with the patient minutes before. This time, investigators acted immediately. She was taken into custody for questioning. At first, she denied everything. Then, inconsistencies appeared. She couldn't explain why she had access to certain drugs. She couldn't explain why she was present for so many emergencies. Eventually, the truth emerged. Beverly Allitt had been intentionally inducing medical crises, sometimes to cause harm, sometimes to play the role of rescuer, sometimes simply to watch the response. She was later convicted of murdering 4 children and attempting to murder several others. The revelation shook the medical world. Parents who had trusted her replayed every interaction in their minds. Doctors questioned their own instincts. Nurses wondered how many signs they had missed. Investigators later said, the most disturbing part wasn't how long she went undetected, it was why. She didn't fit the profile people expected. She wasn't cruel, she wasn't aggressive, she wasn't outwardly unstable, she was helpful, calm, always there. After the case, hospitals around the world changed how they track medical emergencies. Patterns mattered more than explanations. Statistics mattered more than instincts. Because sometimes the person you trust most is the one closest to the harm.